So, hey, everybody. Welcome to the virtual Rehab Summit. And my name is Lisa Wright, and I'm from Corpus Christi, Texas. And I am a 7-year fan of the Functional Aging Institute and a functional aging specialist. And I am delighted this morning to introduce an icon in our industry. Thought you'd like that.
That's a good ad lib. I like that.
Yeah, and so I'd like for you to join me in welcoming Dr. Evan Osar. Evan Osar is an internationally recognized speaker, author, and expert on assessment, corrective exercise, and functional movement. He has authored corrective exercise solutions to common hip and shoulder dysfunction, functional anatomy of the Pilates core, and Amazon #1 bestsellers, the SOAS solution and the pain-free exercise blueprint. He has developed the industry's most advanced training certifications, integrative corrective exercise instructor, and integrative movement specialist. With his wife, Janice Maddock, am I saying that right?
Correct.
He created the Institute for Integrative Health and Fitness Education. This is an online educational resource for the health and fitness professional that specializes in working with the general and older adult populations. And I certainly know that's our situation, and we love your stuff. We incorporate it weekly and daily with our clients, probably even just this morning. So welcome, welcome, Evan, and it's all yours, and I'll be on standby if you need me.
Awesome. Thank you. I really appreciate the kind words and for being part of this wonderful inaugural event. Anything Functional Aging Institute is involved with, Lisa, you know, we love to be part of, and truly appreciate all of you being on live, as well as anyone listening to the recording here. So let's just shift it over to my screen. Could you actually enable screen sharing, please? So I'm glad you didn't go away. Try now.
Yeah, I'm not going away. So let me get to screen share. Can I probably I need to pass the host to you. Let's try this. There you go. Try that.
Ah, there we go. Perfect. Thank you.
Okay.
All right. Hopefully you guys can all see my screen now. Is that all good? All good by your side, Lisa?
Looking good. Yes.
Great. Thanks so much. All right, guys. Thank you so much again for joining. And one of the things we're going to talk a lot about today is posture, and ultimately how postural strategies lead and contribute to pain, and how you can use postural strategies to reduce pain, even eliminate pain in many of your older clients, and at the same time improve performance. Because as we'll discuss during this presentation, I'll demonstrate, and I want you to experience this in your own body, posture, pain, and performance are inextricably linked. So they're not separate things and or topics or concepts. They actually relate to each other. We'll talk about the different kinds of pain, because if you guys have been following social media over the last couple of years, there's been a big knock on posture and how posture and movement strategies don't matter. And posture, I should say, pain is all in the individual's brain and nervous system. And to a certain extent, that is true, but there are different types of pain clients or pain patients if you're in the rehab setting. And I want to describe which ones do respond very well to posture, movement, education, and ones that don't respond as well, and that need that cognitive or that psycho-emotional component to their training. And remember that regardless of what you're doing with your client, you're always creating an emotional change in their body. I should say, not always. You're usually, while they're having positive results with you, there is that link to emotions. So we want to always bring that to our awareness as clinicians, as physical therapists, as chiropractors and fitness professionals, that we're always impacting the psyche of the individuals as much as we're physically impacting them as well. I want to begin with a client of mine. This gentleman, Tom, looks very similar to a lot of the clients that you see. Now, Tom presented with chronic low back issues. He had balance issues as well as foot pain as well. He was working with a personal trainer himself when he first came in to see me. He was doing all the traditional sort of strengthening type things, posterior chain strengthening. And he's like, yeah, I'm really working on my balance and stability, but I'm still having this pain and my balance really hasn't improved. And this foot pain is actually getting worse. Now, this is Tom 30 minutes later. It's not 3 weeks later. It's not 3 months later. It's not 3 years later. And the important thing I want you to take home from this slide and this image here, that this is not a strength issue, because oftentimes we'll see Tom or a client that looks just like Tom in the image to the left there and say, oh, he just needs to get stronger. And that may be true. Yes, our clients need to get stronger. And given all things equal, the stronger individual will perform better. But we're not comparing apples to apples in this situation. When a client has a suboptimal strategy, which Tom has, more strength oftentimes just reinforces that suboptimal strategy. And that's the reason why your clients are getting tight and or have discomfort and can't perform or unable to perform at the levels they need to and or want to. When we give our clients a more optimal strategy, I'm going to share with you exactly what I did with Tom to make him look like he did in the picture on the right. And it wasn't just stand up straight, pull your shoulder blades down and back, pull your abs in. In fact, what Tom said to me as I took that picture and showed it to him, he said, I don't even feel like I'm trying to be in this position. And that's what I'm really referring to here. That's all about your client's strategy. So I want to leave you today with some concepts, key concepts and principles that can help you create instantaneous changes in your client's posture and ultimately lead to overall enhanced performance, because that's really what it's all about. And in that process, often decrease pain and not chase pain. And that's one of the most important things as a therapist that I wish somebody had really expressed to me early on is don't chase your client's pain. Don't chase their tightness. Chase helping them create a more optimal strategy. Because even when pain doesn't change, their strategy improving, or when your clients see these before and after images or before and after videos of themselves performing, they get really encouraged. They get empowered to continue on in this process. And that's one of the things we'll discuss during this presentation as well. So 3 objectives today. Discuss why you need a better system, a strategy, and not more posture exercises, because you all know the posture exercises, stand up tall, squeeze down and back, pull your abs in, all the things that create the superficial postural changes, but oftentimes don't lead to any long-term changes in your client's strategy of how they actually move and perform in their bodies. To demonstrate a common cause of postural dysfunction and how to use motor control training, another way of saying motor control is corrective exercise. Corrective exercise is motor control training to improve posture, to improve postural strategy, and ultimately improve performance. And at the same time, as I mentioned, decrease pain in the process. And to demonstrate functional exercise progressions. So at the end, I want to take you through exactly what I share with you as I demonstrate in this presentation, so that way you can feel it in your own body, because it's really easy to sell to your clients. You don't even have to sell it to your clients. You're just educating your clients when you feel the changes in your body. But one of the biggest challenges we find in our industry and people that come through our work is when they don't do the work and don't feel the changes in their own body and start to recognize when their own body is off, it's hard to sell it to your clients. And then you have to try to sell it. You're like, yeah, this breathing thing is really important, but I don't do it, so I don't really feel the changes. But I know it's important because Dr. Osar said it was important. No, I want you to feel in your body how breathing can change posture, can change range of motion, can improve stability. We'll go through that later here today as well. So again, thank you for joining us. Thanks for allowing us to be part of your day and part of this very important sort of event, because it's really an opportunity for us to come together collectively as an industry to create a collective solution to this healthcare crisis, because we all have our expertise. We all have our specialties. None of us have all the answers together, but together as chiropractors, physical therapists, manual therapists, fitness professionals, medical professionals, we can come together and use our collective expertise to make a dramatic change in our older adult population. And I truly believe we can change the healthcare system, and we can be the solution for our older clients as well as younger clients as well. So once upon a time, we all had optimal posture and movement. I love this picture here. And if you would like, take a screenshot of this, because it's really a great illustration of what posture once was. The posture that almost all of us, there's exceptions, but 95% of us, 90 to 95% of us all had this posture at one time before life got to us. We were able to stack our rib cage over top our pelvis. So we created that cylinder appearance. And you can see the beautiful cylinder appearance of this little girl here with her rib cage stacked over top her pelvis. And you also see her head perfectly aligned on top of her cylinder. So she's got beautiful alignment of her head and neck over top that cylinder as she looks down at her toy cell phone, which will very quickly be a real cell phone. So when this is a great image to show your clients, to show them that we were all once there before life got to us. And my little niece here, Sasha, when she was at about 3 to 6 months there, you can see she can easily put her foot in her mouth. She can do cute little rotations and look awesome doing it and not have to strain herself to do that because she wasn't influenced by life at this point. However, then life happened to us. We started very early. Many of us started very early. And that's why I included this picture on the far left. You see the child in this sort of Johnny jump up or whatever they're called these days, bouncy little apparatus. And children love this. Parents love it because they can stick their child in it and they can walk away and not worry about them because the child doesn't go anywhere. And the child loves it because they're upright, they can see further, and they also are upright and they can bounce up and down. They love this thing. However, will directly relate to postural issues in later life and start to train muscle imbalances because what it does a couple things. First of all, you see the baby on her toes or his toes, and he's already in plantar flexion. So he's already developing his plantar flexion relative to dorsiflexion of his ankle. Another thing is this child is way too young to be in the upright position. His pelvis and his hip joints are not developed to the point where they should be supporting him in the upright position. The angle of the femoral necks and the head position, the femoral head, the ball and socket joint isn't formed for the upright position yet. That's why crawling is so important. That's why rocking is so important. That's why starting to go into half kneel is so important because those positions and those patterns start to develop the optimal alignment of the pelvis, the lower extremity, as well as those hip joints so they can support the upright position. So this is already tucking the little child into posterior pelvic tilt and also changing the angle of his hip joints. So again, you have muscle imbalance and changes, but you also have the structural changes to the joints. And that's why I highly do not recommend this to clients. Get your children out of these positions, out of these play apparatus, get them down on the floor and crawling. Obviously, now we have a huge problem with our children spending too much time in front of computers and games and not getting enough uprightness and exercise. So again, we already are developing these issues from childhood and then into adolescence as well. And then most of us and most of our clients have gone on to sedentary jobs. They went from college, or maybe they didn't go to college, just went to a job where they sat for the majority of their life. Janice and I both my wife Janice and I both come from a family, our fathers were truck drivers. So they sat most of their entire life, even though they were very active, they were still sitting a good portion of their life to and from work and working as truck drivers sitting. And then we have development as the older adult. Many of our older adult clients haven't been empowered to be active, which is why this is so important and why your message is so important to get out there and share with this community and why we love being part of Dr. Dan Ritchie and Cody Sipes' Functional Aging Institute and this summit event right here. Now, along the way, not only did life happen to us, but we had things like injuries, sprained ankles. We may have had broken bones that started to change our posture and movement strategy. It started to change our soft tissues. Maybe some ligaments got overstretched. Some ligaments became tightened. We may have had surgery like C-sections or hysterectomies or other gallbladder surgery. I've had clients, a client that came in, she had a gallbladder surgery at 16 years of age. And here she was in her 60s. She was having digestive issues, constipation. She was also having chronic low back issues. And we talked about the importance of, or I should say the relevance of that surgery to her posture, that now here she was, literally 50 years, 40 to 50 years later, that surgery impacted her development at 16 years of age. And she was a professional dancer. She became a professional dancer in her career. But here she was at 60 years of age when she first came to me with chronic low back issues. This strategy, I should say, the strategy she developed, the compensations were related to her surgery way back then. So it's important to take a thorough medical history so you understand the events that have impacted your client's posture and movement strategy. Obviously, chronic pain also can change people's posture and movement strategy and will change. And then a lot of these strategies will lead to things like joint replacements. And many of our clients will have joint replacements and get rid of the instantaneous pain, but they're leaving rehab with incomplete rehab syndrome where they're not as strong or as stable as they could be. So it's important for you then as a fitness professional to take these clients and help them progress back towards accomplishing their health and fitness goals so they don't further deteriorate or wear out their other side, which commonly happens as well. And then we wonder what happened. Our clients come to us and say, hey, I used to be more active. I used to be more mobile. I used to be able to touch my toes. I used to be able to get down on the floor and get back up. They're like, I don't know what happened. Well, life happened. All these things that we've been discussing that you're aware of have happened to us and created the strategy that your client now comes in and wants help with. They want to feel better. They want to get stronger. They want to live a more active lifestyle. However, they don't know how, and their doctors and healthcare professionals often don't give them a great way of how to make that happen. Again, this is why your message is so important and why it's so important that you get out in front of these people and help provide them strategies for improving the quality of their life and taking the burden of these musculoskeletal issues off the healthcare system. You are that solution. So one thing we want to just note about osteoarthritis, because some of your clients will come in and what I hear from a lot of gym owners that we consult with is they'll get very frustrated because their client will go to their medical doctor and they'll say, oh yeah, you have pain in your hip, take 2 weeks off from the gym. When that's the last thing they should be doing. They should be in the gym and in their facilities with you working out or doing it virtually. They shouldn't be taking this time off. And I know my good friend Jackie, you hear me mention her name all the time, but she sort of went on a sort of got on her soapbox a little bit on her Facebook page to her clients. It's really a call to her clients that don't wait for COVID to be over because we're already now 6 months into COVID, maybe further, maybe we're more 7 or 8 months into COVID. It's not going away. There's no vaccine on the near horizon, maybe next year at the earliest, this time next year, maybe, but the vaccine's not out and about. So this thing is going on for a period of time. So we need to encourage our clients to get out there and be proactive about their health. Do not let your health deteriorate and be passive about this. So we have to get that message out. And I 100% supported what she was saying to her clients, because if the doctors aren't telling their clients the same message. So what happens is our clients go to their doctor and they're like, hey, is there anything I can do about my bad back or my sore hip or my knees bothering me? And they'll say, yeah, no, it's basically just genetics and old age. And so many of our clients have heard that. Raise your hand if you've heard that from a medical professional or you've read that somewhere. It's not age. It's not your genetics. It's not even your weight, because a lot of clients have been told like, hey, if you lose more weight, your joints will hurt less. No, that's not true. We got scrawny little people coming in our office. And I don't say that to be derogatory, but we have skinny, active people coming in 50 years of age that need a joint replacement. It's not weight. It's not your age even. Age is just a representation of what you've been doing to your body. So what is it? It's really about your repetitive injuries, the acute traumas, and the strategy, the habits that have been set up over the course of time. Now, we were teaching this for years, even though there wasn't much evidence to support this. But a recent study came out, Dr. Wallace out of Harvard looked at skeletons, pre-industrial area compared to post-industrial area. So he looked at the bone density. He looked at the cartilage, or I should say the end surfaces of the bones, like where the bones form the joint, because knee arthritis has increased tremendously in the last 100 years. So what's different about the last 100 years prior to the pre-industrial revolution? So what Dr. Wallace concluded was that aging really isn't, or I should say arthritis really isn't about aging, it's about activity. Dr. Wallace thinks the most obvious candidate to explain the increase in knee osteoarthritis is the modern decline in physical activity. I'm going to add something here. It's not just the modern decline of physical activity. So it's not just the quantity of exercise. I also believe it's the quality of exercise. So if you're taking notes, and I hope you are, please write that down. Not just quantity, it's quality, because there's clients out there that have been told, go walk 10,000 steps, but they have a significant valgus knee position. So 10,000 steps in a valgus knee position, especially if it's asymmetric, or it could be bilateral, but if it's asymmetric, you're going to overload your knee joint or compensate and overload your hip and or low back. So it's not just quantity. Yes, we must increase quantity of exercise and physical activity, but we also must help our clients, our individuals, develop a better quality of posture and movement. And that's why I'm happy you're here. And this is what this rest of this presentation is all about. Now, what about genetics? Because does genetics actually matter? Of course they matter. But I love this statement by Dr. Caldwell Esselstyn. He's out of the Cleveland Clinic, I believe, or he's retired. And he said, genetics loads the gun. It's your lifestyle that pulls a trigger. We all have a certain genetic code. Some of us have better joint cartilage. We have better, thicker cartilage, or we regenerate cartilage better than others. Some of us have thicker joint capsules, so the ligaments and capsules around the joint are thicker and stiffer, so they help to support the joint better than others. Others have more flexible ligament and joint capsules. That's just how your body is, the hand you were dealt, so to speak, in life. But what ultimately determines the health of your joints, the health of your body, the health of your physiology is what you do through it or with it through the course of your life. And that's why this quote is so great. Again, remind your clients of this as they start complaining about the fact that their mother had bad knees and now they have bad knees as well. So more specifically, osteoarthritis is about your client's habits. It's how they're sitting, it's how they're bending, it's how they're squatting. If you look at this client here, or I should say this gentleman here sitting, you see his rib cage stuck behind his pelvis. And this is how the majority of your older clients are sitting and sat their entire life. That's the majority of how all of us sit because of the nature of what sitting does. It causes posterior pelvic tilt, lumbar spine flexion, increased thoracic spine flexion, and then the client has to compensate. And so what happens for a lot of these clients, then they go to bend over. And you see a very common strategy for when clients bend over. You see this gentleman doing probably about to do a burpee. I believe he's doing a burpee here. You see the posterior pelvic tilt, the increased thoracic kyphosis and flexion. You see the extension at his upper back and neck, and you see the knee bend because he doesn't have great anterior pelvic rotation. And that's what happens. You start to overload other joints because you're not loading the joint where you should. You're not getting equal contribution from all joints. So you start overloading joints that actually move very well. And the thoracic spine is a very easy area to compensate from. And then ultimately, you can have situations like this where this individual squatting and his tibia is turning out. His knee is facing forward, but his tibia is turning out. This is a very common strategy. I'll show you why here in a moment. Actually, let me show you right now. So what will happen for a lot of our clients, I'll just stop screen share just for a moment. What will happen for a lot of our clients is when they lose stability or ability to stand on one leg and control their posture, especially walking. When we think about walking, it's a single leg effort. It's bilateral stance, but then they get into single leg stance. If you don't have a good ability to stabilize yourself in single leg stance, well, then you'll start to move through the frontal plane. You'll start to shift your pelvis or you'll start to shift your body to get your weight over top your support, which is your foot. So what happens for a lot of our clients, and to add to that, they'll also lose rotation. So what tends to happen then is when our clients walk, if you lose rotation, so you lose the ability to rotate and you start to side bend, well, now you have to compensate for that because having a straight foot like this is not very stable if you're starting to side bend and do a waddle gait as I referred to it. So what happens is they'll start to turn their leg out. So when they step over this way, they're more supported. And they'll step over this way, they're more supported. So that way they start to develop this sort of duck or waddle gait because they need to turn the tibia out, rotate the tibia out to create a more stable platform. And that's why so many of your older clients, you'll see that tibia and external rotation, and that will further degenerate or lead to degenerative changes in the knee. And that is such an important concept because if you don't change that alignment, but you keep working on balance, then there's going to still overload that knee. And again, remember, it's not about age. It's not about your genetics. It's about the strategy that you've developed to make up for, to compensate for the lack of rotation and or the lack of stability in single leg stance. Now, if you have any questions during this presentation, feel free to type them into the chat down below and I will answer the questions. I'll take a little break here. Once I get through the lecture portion, I'll take a little break before we get into the sort of the interactive. So let me go back to share screen and we'll leave time at the end for questions as well. So remember, osteoarthritis is really about your client's habits. Most of the reason why your clients have pain is their habits. They're starting to overload an area of their body to compensate for the lack of range of motion, the lack of stability, or some of these injuries, surgeries, and traumas they've had earlier in their life. They will also compensate for some of their postural issues, and we'll talk more about that as we get a little bit further into the presentation. So remember, posture, pain, and performance are inextricably linked. Not 100% of the time, and not in 100% of your clients, but oftentimes they are. Because when you start to develop strategies like my client there in the image to the right, it doesn't look anything like the baby strategy. His head and neck are not stacked over the thoracolpelvic cylinder. The thoracolpelvic cylinder, that cylinder appearance, is not even stacked up. You see the thorax is behind his pelvis. You see the increased sway in his low back. You see the abdominal distension. So you do not see the same strategy. So he is already compensated. And basically what this client is showing you is that he's basically compressed down. So gravity, his muscle contraction, as well as the lack of three-dimensional breathing, all compress his body and then all lead and contribute to that compensatory strategy and reinforce the habits that he has. Hence the reason he comes into you when he's at 50, 60, 70 years of age and says to you, hey, I've got this chronic neck pain or chronic neck degeneration. I just saw a gentleman, Robert, in my office the other day. He had just come from his doctor. He's like, I have cervicogenic vertigo. What that means is he's got vertigo, dizziness coming from his cervical spine. And he's like, when I turn my head, you could physically, actually, it's not audibly hear his crepitus in his neck, this click, 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 as he turned his head to the right, and he could barely turn it to the left. So he's like, yeah, it's painful. So basically what I did is I just decompressed his rib cage, taught him how to breathe, gave him a little cue to traction out and lengthen through his neck. He's like, I can turn my head with no clicking or crepitus. And then when I just had him relax it, then he scrunched back down. He looked very similar to this gentleman here, went right back to crepitus and clicking. So the cues that you use to your client or with your client are so important as well. I'll share with you the cues that we use to help create more space, more of this concept that we refer to as suspension, and to help decompress your client as they exercise and as they live their life. So basically, the degenerative joint process, we call it degenerative joint process because it's a process that happens. This client here, she came in with, she's got osteoarthritis, significant osteoarthritis of her right hip, but she came in with left ankle and foot pain. So what you see here is she's actually rotated her entire left side in. She's got rotation through her femur and her tibia. You see she's on the inside of this left foot. She's compressing the lateral point of her ankle, the lateral aspect of her ankle, exactly where her foot is, because she's trying to compensate for the osteoarthritic changes in her right hip. You can even see she's got atrophy on this left side. So the more that she compensates through her hip and knee here on the left side, the more atrophy she's gotten, not hypertrophy. She actually has more hypertrophy on her right side, the osteoarthritic hip, because now she's not using her hip as well. So now she's overdeveloping her right muscles to make up for the lack of her left calf muscles. I should say to make up for the lack of her being able to use her hip. So a lot of these things that you see in your clients, they're compensations for other areas in their body. And that's why I always teach, when I teach physical therapists and chiropractors, I say, don't chase your client's pain. Chase their strategy and help them improve their strategy. So that way they're deloading or unloading the pain, generally the painful area or the compensatory area. This lady, unfortunately, she just needed a hip replacement. So even though we were able to help her temporarily until she gets her hip replaced, she'll continue to feed back into this pattern. This gentleman, on your right, he came in with again, a classic forward head, the cervical extension, the lower neck extension, the increased thoracic kyphosis with the thorax position behind the pelvis, posterior pelvic tilt. He's got abdominal distension and diastasis recti, so splitting of his abdominal wall. So again, these posture and movement changes started a long time ago. As you see your clients in their 60s or 70s, this is just a manifestation of what they've been doing year after year after year. That's why it's so hard to change. But I'm going to share with you here in a few moments a strategy for creating instantaneous as well as long-term changes in your client's posture and movement strategy. But the first thing that changes is posture and movement habits. These habits are developed by the things we've learned about posture. So for example, my wife, when she was young, she was taught, when I say young, like 5 years of age. So I just want you guys to take a look at me. What she was taught by her mother was, at a very young age, she was taught to, she was a chubby little girl. So her mother, again, well-meaning, this was no knock on my mother-in-law, but she was taught to bring her chest up, squeeze her abs in, tuck her tushy under, and pull her shoulder blades back. So she was a really good rule follower, and she did that. Well, she was taken to the hospital when she was 5 years of age because her parents went into her room one night and found that she had turned blue. She wasn't actually breathing well. And soon after that, obviously she survived, luckily, but soon after that, she developed chronic migraines. She was given medication. She was told to stop eating the foods like chocolate and cheese, and she's from Wisconsin. So, that wasn't going to happen. So when I met her at 25 years of age, she had 20 years of migraine. She was living off, or she was on birth control pills that stopped her menstrual cycle. She was on ibuprofen virtually every single day, still was getting chronic migraines almost every week. Like virtually every week she had migraines. One of the things we looked at is what I noticed, like her rib cage was super narrow. So it wasn't round like a cylinder. It was narrow like this. She had the narrowest front to back rib cage I had ever seen up to that point. And she had chronic neck problems because she had begin her career as a manual therapist. So she was doing a lot of massage at the time and carrying her massage table. So she had chronic neck issues as well. We taught her how to breathe. We taught her many of the strategies I'm going to share with you here. Within 18 months, she was off all her birth control pills. She was off ibuprofen. And we just moved, like literally a month ago, we moved to Wisconsin to be closer to her parents. We found a bottle of ibuprofen from 2005. That was the last time she had taken ibuprofen. And it was really a testament to this work and this information that you can change, you can transform people's lives. Think about my wife now, 15 years, she could have been on birth control pills and had no menstrual cycle. She could have been on ibuprofen, tearing up her intestines and creating soft tissue changes with the ibuprofen. And here she is. She was able to use some certain specific principles to completely eliminate migraines. She does not get migraines at all. And if she gets a headache, it's usually because we've been traveling a lot, which obviously is not happening during COVID, or maybe she drank a little bit too much and didn't drink enough water. But again, no migraines. So this stuff is powerful. You can change your clients' lives with this information. So it's also about the injuries and traumas. We talked about that, broken bones, the injuries we had as children or adolescents, exercise, even exercise habits. We'll talk about those here in a moment. Repetitive trauma, sitting or running are both repetitive traumas, or the sedentary lifestyle. Many of your older clients are coming to you with a sedentary lifestyle. Okay, let's talk about exercise habits, because this is what's happening for a lot of us as health and fitness professionals that have chronic issues. We often see clients performing patterns like the bird dog. And I'm a big proponent of watching clients do remedial exercises. And here's why. A lot of us say, hey, go do your remedial exercises and I'll catch up with you for the high intense exercise. But I love this quote, and I believe it's Hebb's law. Neurons that fire together, wire together. Because your clients often see bird dogs and some of these basic fundamental exercises, these traditional introductory rehab exercises, as boring or tedious. So they start doing them in a manner that doesn't facilitate optimal alignment and control. If you look at these three gentlemen of different ages here in the far right image, none of them are doing an effective bird dog, but this is how the majority of clients, when I see them, this is how they're doing it. This is what I see in the gym every single day, is clients doing the bird dog like this. They're not using optimal form. They're not using optimal alignment or breathing. And they're just reinforcing this neuronal firing and wiring this pattern into their nervous system. We see clients doing lat pull downs or rows or pull-ups in this exact manner. This is exactly how I was taught to do this way back when I was in bodybuilding world back in the 80s. Yeah, I'm dating myself a little bit here. Back in the 80s, this is how we all got taught to do it. And people are still doing this. I see this in the gym every single day, overdeveloping their thoracic extension, overdeveloping their lats, pulling themselves into that flared rib cage position. This is why so many of us as health and fitness professionals have chronic neck and or shoulder issues and even low back issues. And obviously how we're teaching people to deadlift. This pattern right here, how this woman's doing this. This is a powerlifting specific type of deadlift where you really pull your shoulder blades down and back. You really brace your core and you drive that pelvis forward. That strategy is specific to powerlifting, but it's made its way into everyday working out, because this is also what we see every day in the our gym facilities, as well as our clients are learning this exact same strategy. I was at a conference a couple of years ago, and there's a very popular presenter there who teaches people to thrust their pelvis into the bar as if they're doing something naughty to the bar. And he comes up to me, and we're on a panel where we're all up there together. And he comes up to me and he sits down next to me. He's like, "Hey, you're the hip guy, right?" I'm like, "I mean, I guess I'm the hip guy. I wrote a book on the, hip and shoulder, so I guess I'm the hip guy." He's like, "Yeah, I had my one hip replaced, and I'm about to go have my other hip replaced. Do you have any advice?" And I wanted to tell him, stop teaching people to thrust their pelvis into the bar like you've done. That's why you have hip replacements, is because you've done strategies and you've created habits that are directly contributing to wear and tear of your joints. Hence the reason you have bilateral hip joint replacements at this point. And here's the thing I want to stress to you, and I'm not trying to say that I'm smarter or better than anyone, but here's my thing. I've shared with you my story about having bilateral rotator cuff tears, bilateral labral tears in my shoulders, because of the habits I created and was taught from a very early age from lifting weights, from my bodybuilding days all the way to rehab, all the way to most conferences I go to, all teach the same strategy to do with the shoulders. And I tore up my rotator cuffs and my labrums in my shoulders as a result. Just like this gentleman tore up his hips because of his exercise habits. And what's frustrating to me a little bit in this industry is when those individuals that are having surgery on their torn up body parts are trying to teach us what to do with our joints to maintain joint health. So it's like you're trying to get me to understand, like, you tore up your hips using this strategy, but now you're teaching me the same strategy that tore up your hips. So now you want me to adopt your hip strategy. So that doesn't make any sense to me. I will tell you what to do about your shoulders so you don't do what I did to my shoulders, but this is not what I do anymore. I don't do any squeezing down and back. I don't do packing my shoulders. I don't do scapular retraction and depression anymore. And that's how I'm able to continue to work even despite rotator cuff tears and or labral tears. So if you're following someone, and I know my good buddy, Robert Linkle, he's got bilateral hip joint replacements as well. But one of the reasons we're working together is so that we can help each other develop more optimal habits. And that's why we've created the Arthritis Training Solutions, so that you learn, so we can teach you what not to do to tear up your joints. So just keep that in mind when you're learning from the people that you learn from as well, okay? So the first thing that happens is you change posture movement, as we described. But as you go through that process, now you start to create soft tissue changes. Muscles and tendons are soft tissues. You start to over-lengthen some muscles and tendons, and you start to shorten other muscles and tendons around the joint. You change the fascia around the area. If you start to have thoracic kyphosis, you stretch the fascia in the back, you shorten the fascia in the front. You change ligaments and joint capsules, the things that hold your joints together and maintain fluid inside the joint. You change cartilage. You start to wear cartilage out, or meniscus, or the labrum, or the disc of your spine. This is an MRI. If you see this image here on your screen, this is an MRI, the side view of a lumbar MRI. Let me just orient you if you're not familiar with it. This right is just above where the purple arrow is. That's the L5 vertebrae. The L4, L3, L2, L1. You can see T12 there. The spinal cord is that bright white column there. And then if you look in between each bone, you'll see a little circle of white. Mostly at the top, you'll see it. You'll see it sort of midway through. I don't know if you can see my pointer. If not, that's okay. But as you get down to where my pointer, or where the arrow is, that purple arrow is, you see that it's a lot blacker. There's not as much fluid in that disc. And you see that disc pushing back into the spinal cord. So that's a disc bulge or disc herniation. That can be a cause of pain, but it can also not be a cause of pain for some individuals. But for some people, especially people that are in the pain research, they'll say, oh yeah, everybody's had disc bulges, they don't cause pain. For some people, they absolutely do cause pain. They cause massive pain. That's not just in their head. So the other thing I want you to think about with these soft tissue changes like disc bulges is think about your MRI. Where are MRIs done? They're done while you're lying on your back. Do you know where there's the least amount of pressure on your lumbar spine and on your spine in general? It's when you're lying down on your back and not moving. That's why people that have chronic low back pain will generally lie on their back and elevate their legs. Because if you were able to see your client move, you'd see a very different story. You'd probably see a much bigger disc bulge if the client was actually upright, if we were able to take the MRI in the upright position and or have them move as they're doing their MRI study. That's why it's so important that we understand these changes. You change posture and movement, and then you start to change the soft tissue structures, okay? And they don't always heal exactly the way they need to or that we want them to. Sometimes they do, absolutely, but other times they don't. So just because some person who has a disc bulge and has no pain doesn't mean that every person that has a disc bulge will not have pain. So some people do have a very painful disc that's provoked in certain positions, like sitting too long or bending incorrectly. Over time, if these posture and movement habits continue, if these soft tissue changes continue, then we start to create bony changes. And you'll see my clients' knees here, especially this knee in the image to the right here. You'll see the decreased joint space, bone on bone. That's advanced degenerative changes of the knee. Where the cartilage has degenerated, the meniscus has probably degenerated to quite a bit as well. The ligaments have tightened down on the side of the knee, and now you have bone on bone. Same thing in the hip joint here. You see no space in the hip joint or the ball and socket joint there. And even in the spine here, the x-ray of the spine, you see decreased joint spaces between the lower vertebrae, and you see bone spurs sticking out. And it's basically Wolff's Law. Wolff's Law states that a bone will remodel based upon the stress that's put on it. So if you overload the inside of your knee or the outside of your knee, depending on if you're valgus or varus stress on your knee, you will start to develop more bony changes. You'll start to wear and tear on the cartilage even further, and you'll start to decrease your joint space. In your hip joint, it's no different. I'll share with you a strategy here in a moment that leads to lots of joint replacements, just like the industry professional I was describing. And also it leads to changes in your spine. This will decrease range of motion. It can cause pain, but a lot of people will have osteoarthritic changes and have zero pain from it until it gets more advanced. And you talk to anybody that has a joint replacement, by the time they have their joint replacements, they're usually in quite a bit of discomfort. That's why it's oftentimes a good thing to recommend to your client. Again, when I say recommend, if you're not a health and fitness or a health professional, if you're a fitness professional, educate them about if they're in a lot of pain and they're trying to avoid a joint replacement, don't have them wait too long, because the more they wait, the more they're compensating and overloading other joints. I have a client right now. He used to be a junior Olympic martial artist. Now he's got a significantly degenerated hip, but he's got no pain. And we've actually been able to improve his range of motion with the work that we did that I'll share with you here in a moment. He's like, when should I have my hip replaced? And I said to him, you should probably have it replaced pretty soon, because you're compensating so much through your knee now. You're also compensating a lot through your back that you will create issues. He's already creating issues. His knee's getting a little bit thicker on that same side of his hip joint, osteoarthritis, and you will compensate. He's also compensating through his low back. So I'm like, I would do it now. You don't, again, it's not an emergency, but start to find the surgeon, start to plan when you want to do it so that's most convenient for you. Because if the longer you wait, the more you'll compensate, and then you start overloading other joints of the body as well. So again, here's the degenerative joint process that we just discussed, and it's basically a self-perpetuating cycle. You have non-optimal or suboptimal posture and movement habits. We talked about all the reasons why, or a lot of the reasons why these habits develop. Then we create soft tissue changes. So muscle length changes, fascial length changes, ligament and joint capsule length changes, as well as cartilage degeneration of the labrum of the hip or shoulder, as well as meniscus or the discs of the spine. And then ultimately we create osseous or bony changes. The skeleton and the joints start changing based upon the stress that's been placed upon them. And then this becomes a self-perpetuating cycle. However, at some point, it starts to go in reverse too. The bony changes start to create more soft tissue changes. The bony changes can also create different posture and movement changes as the client compensates. Soft tissue changes to get away from pain or discomfort. The individual can adopt different posture and movement. So it can go either direction, any direction. And that's what ultimately makes this process so challenging to change in your clients, because by the time you see them in their 70s or 80s, this process has been going on a long time. So does this just posture, pain, and performance, are they linked? There's lots of research. There's a lot of people out there saying, pain scientists that are saying, hey, no, posture and pain are not linked. They are linked if you look at the right studies. And one of the things you can look at also is the function of muscles. It also impacts the function of muscles, which ultimately changes how the individual will stand and move. So there's a study that came out in 2017 where they looked at the cervical muscle thickness between asymptomatic women with and without forward head posture. And basically the forward head posture in women that had no pain. So this is very important because we want to also look at people that don't have pain. What do they do? And do they have changes? The forward head posture was correlated with an increased use in hypertrophy of your SCM, the muscles in front of your neck, sternocleidomastoids, and decreased use of the deep cervical flexors. So that starts to change the relationship of how you control your head and neck. Now think about that client that has this issue, the forward head, and now they get in a car accident. Now they slip on the ice and fall and get a whiplash. Which individual will probably respond better, or which one responds more, will have more probably issues related to that car accident or that fall? Probably the client with forward head, because she already has that muscle imbalance. And they've shown that, Gwendolyn Joel has shown that in studies, that people that have had whiplash, they have a different reaction to the motion of their neck. They tend to use their SCMs way more than people that haven't had a previous whiplash injury, because of these changes in muscle function that happen related to the forward head posture and also pain as well. So imbalances between the deep and superficial muscles commonly perpetuate neck pain and impair performance. And again, we don't want to focus on pain. We just want to recognize that pain is related to how our clients, to their client's postural strategy. And this is a client, I'll share with you what she's doing and why she has chronic shoulder issues. She has chronic shoulder and back issues. And you see that she's a very characteristic, she's a younger client, obviously, but she's got a very characteristic hyperextension of her back with the shoulders pulled down and back. And she also has a forward head posture as well. I'll share with you the cues that we use with her to change that strategy. So one thing I want to note before we get to the exercises is the diaphragm. Obviously, if you've heard me speak before, thank you again for tuning in. The diaphragm is a huge part of what we do from a posture and movement strategy. And when you think about the diaphragm's function, its many more functions than what I listed here: respiration, postural control, and mobility. Early on in development, the diaphragm is purely a respiratory muscle. But around 3 months of age, the diaphragm also takes on a dual function of postural control. So it functions in respiration and postural control. So now think about your older clients coming in. How many of them would you say have an optimal breathing strategy? Probably 5% of them, right? So 95% of them do not. So how can they have good postural control or mobility if they're not breathing well? So what does the research say? Because if you want to look at research, the research says the people that have better diaphragm thickening, which means the muscle's working more effectively and is actually stronger, have better balance. 2018 study showed that. What they've shown in people with aging in the diaphragm is there's atrophy and decreased trunk and spine and organ mobility when you have decreased strength in the diaphragm. The diaphragm strength decreases by 30%. Think about this. Think about the thing you do most in your life, breathing. You have 30% decrease in capacity. And many of your clients come in to see you, they have more than 30% decrease in strength. But the cool thing about this information is like, it's so dramatic, but you can change it so easily as well with the right focus. But all of this leads to increased joint compression and then those osteoarthritic changes that we talked about earlier. So when you see a client that looks like my client Tom there, what you should be thinking in your head is, not I need to get him stronger, but I got to get him breathing better so that I can help him improve strength and not further compress his body. Now, remember also, if you've heard me speak before, belly breathing is not optimal breathing because Tom is a belly breather. You see perfect belly breathing here, perfect belly breathing here. But what you don't see is the rib cage motion. Most clients' breathing issue is they don't breathe out well. They breathe in perfectly fine, but they don't breathe out well. And most of them are mouth breathing, not nose breathing. So we want to teach our clients how to do nasal breathing and how to breathe through more of their cylinder and not just into their belly. That's why your clients have this kyphotic posture and the distended abdomen, because they become too belly breathing dominant. So what's the best approach? The most important thing you can do is help your client develop more optimal posture and movement habits. And that's what the integrative movement system is all about. The system for change, the integrative movement system, is all about the process. I'll share with you the process, the principles. I'll share with you how the principles of alignment, breathing, and control can help your client reestablish more optimal posture and movement. And I'll share with you some best practices for incorporating this information with your older clientele. Now, let me just take a moment. If you guys have questions, just let me know. Just type it in. Down in the chat below, just feel free to put in any questions you have, or maybe there's a Q&A. Nope. All right, we're all good. So let's continue. So the integrative movement system is a process, it's a very specific process. And I love this quote by James Clear, the author of Atomic Habits. And in his book, this is really what sold me on Atomic Habits. I didn't need to be sold on it. As soon as I started reading the book, I was sold on it, because everything we do as health and fitness professionals is all about changing our clients' habits. Inside the flap of the book, the cover of the book, he says, "You do not rise to the level of your goals. You fall to the level of your systems." And one of the biggest reasons I failed most of my career as a chiropractic physician and as a movement specialist is because I didn't have a good system and I didn't have a good process to take my clients through. Why I've been so successful in the last 2 years is because I've gotten really good at honing my system, the integrated movement system, and the process. So I want to share that process with you so you too can use this concept in your presentation, I should say in your programs, so that way you can create the same changes I created in my clients with your older clients. So it's a 3-step process. You assess so that you identify your client's habits, you address so you develop more habits, and then you progress your client so you reinforce those more optimal habits. So phase 1 is the assessment phase. This is where you identify your client's current suboptimal habits. These are the habits that are creating your client's tightness, restriction, and changes in range of motion. It gives you a starting reference point. Where were you when you started? And this is why it's so important. I really encourage you, if you don't do this, take before photos and videos, because your client will forget where they were when they came and saw you, or they'll be hyper-focused on the tightness or discomfort that they won't see the changes, the benefit of the changes. You want them to visually see the changes in their body as they start to work with you and have success in your program. This will also help you track progress. So we're always assessing and then reassessing daily, weekly, monthly, and also yearly as well. So I'm going to take you through this real quickly, but I just want to show you so that you get a sense of how your assessments are really helping you identify your client's posture and movement strategy. So we're going to look at these assessments: standing posture, even though we'll skip that because obviously you can't really look at yourself. Single leg stance, sit to stand, walking, breathing, leg lift. I'll demonstrate just a couple of these real quickly, just so you get a sense of what we're looking for in our assessments. If you're with me in here live, what I want you to do is give yourself a little bit of room. So let's just do this together, because I want you to experience this in your body. So first, just get a sense of, my cat wants to experience this as well, and say hi. So just stand with your feet on the floor, and preferably in bare feet. What I want you to do from here is then just feel your feet on the floor and just stand on one leg. Do it a couple times. Stand on one leg, put your leg down, stand on the other leg, and get a sense of which side is a little bit more challenging. Because if your balance is real good, you have to be very precise with looking at or evaluating your client. So for me, when I stand on my right leg, I can get tall. My foot is very grounded. My ankle is very quiet. On my left side, I can still hold it. I can stand on one leg and hold it. But you see, I have to shift over a little bit more. My ankle is a little bit more wobbly. I have a tendency to want to grip the ground with my left foot, and my hip is definitely more gripped. So do that one more time and see if you notice a difference. Right side, my hip not too gripped. Left side, a lot more gripping on this side. And my pelvis almost does that if I'm exaggerating. So you already see that on my left side, I have a little bit of a compensatory strategy. Okay, so that's first assessment. Now put your hands on your hips like this, and now rotate to one side, come back to center. Rotate to the other side, come back to center. You always want to center your clients up so they can feel the difference. Keep your feet together so that you can always come back and measure them at the same exact point. So they're not here one time and they're not staggered stance the next time. Their feet are always together, big toes and heels touching. And if they're too unstable, just move the feet apart, but make sure you put your feet back in the exact same position. So again, turn right, come back to center, and go slow. Turn left, and my left side a little bit more restricted than my right side. So harder to stand on this side, a little bit more restricted, even though it's generally better than it would be because I've been actually working on this side. Now, let's do a heel to toe. So put one leg in front of the other. So I'm gonna put my right leg in front of my left leg. And let's just slide your hands down towards your toes and come back up. Just do that a couple times. And again, if it's too challenging, just move your feet a little bit, stagger stance, and then reverse it. Put your left leg forward. Let's do the same thing. It says which side is tighter. This side for me, a lot tighter. A lot harder for me to go down on this side, my left side, which is very consistent with what I've seen with my other assessments. So just a couple quick, easy assessments to do with your client, and you can do this in a group environment as well. So what's cool about these assessments is you can do them very quickly and easily. That's why I say we assess every single time, because every single time we have our client come in and do 1 or 2 assessments so we know where they are that given day. Cool. I see a couple questions. Let me just see. Would you please expand and scapular retraction? Let me see if we have time for that. For the kyphotic client whose first movement is to shrug the upper traps. Got it. Joey, I'll answer that question at the end. So if I do not answer that question, if you could just ask me again. So he was asking about scapular retraction and why we don't overteach that. I'll explain that more at the end with our final question and answers. Okay, so those are just a couple simple assessments that we do, because that will help us tell us our client's strategy. I'll share with you what that looks like. The other ones look like in a moment. Now, phase 2 is the address phase. And this is where we use our corrective exercises to develop more optimal habits. Remember, our clients have suboptimal habits that are leading to chronic tightness, discomfort, and or not performing at the level they need to or want to. Now we want to use more optimal habits to help them develop more optimal strategy. And this is basically motor control training. It's training the brain to create new motor and neural networks. So we want the neurons that fire together to wire together in a more optimal manner. The principles that we use: alignment, breathing, and control. The same principles my little niece used, the same principles that you and I used when we first developed to create optimal posture and movement. And you see my little niece in this beautiful, happy baby position, beautiful alignment here, beautiful 3-dimensional breathing, in the plank position, the modified plank, and the half kneel or split squat position. Beautiful alignment of the thoracolpelvic cylinder, rib cage over top of the pelvis. Beautiful alignment here of hip, knee, ankle, and foot. Okay. Now, the integrated movement system corrective exercise strategy is release. You release to help align the joint in a better position. You can do that manual therapy if you're a manual therapist. You can do it with self-myofascial release tools. I'll show you real quick using the Rolga here in a moment. Then you have to activate, and this is a very important part. The release rarely changes the motor control or those neural wirings, the neurons wiring to each other. What changes it is the activation, teaching the client a new strategy once you've done your release, once you've got them better aligned and better breathing. I'll share with you how to do that here in a moment. But then the other piece of it, the third component of it, is also the education in the session, but the education that you send your clients home with as well. So here's why education is so important: postural awareness and its relation to pain. This came out of a study in 2018. Self-reported postural awareness is associated with clinical symptoms in chronic pain patients. So their posture was related to their chronic pain. Improvements in postural awareness are longitudinally associated with reduced pain in patients with spinal and or shoulder pain. So posture education and training are necessary for improving functional outcomes in your chronic pain clients. So again, we see this every day in our clinic. You see this with your clients as well. And now the research is bearing that out as well. So creating posture habits that last: 3 things you need: awareness, attention, and an active strategy. Awareness: you need your client to be present. They can't be all over the place thinking about what they're doing later on or where they're going on vacation. They have to be present with you. You've got them for maybe 2 times a week, maybe 3 times at the most, maybe if you're lucky 4 times, but probably 2 to 3 times. You need them to be present and aware of what's going on in the session. You need them to pay attention, to be very purposeful about what they're doing. I love listening to my buddy Robert Linkle talk about how he trains his older adults. He's like, He gets on his clients, as we do here in our clinic as well, because we don't want our clients doing a sloppy bird dog. We don't want them doing a sloppy bend over. We need them being on task, because if they don't do it well here, when are they going to do it well? They won't do it well if they can't do it well in your session. We need it to be active. We need it to be principle-based, and we don't just need them to go home and stretch. We need them to do something active to change these habits. Stretching will not change habits, but it will reinforce non-optimal habits. So again, the cues that I use with this client here is long spine, as if the string's attached to the backside of your head, pulling the client up, and we cue them to lengthen from their back. Cues we want to avoid. This is a client I showed you earlier. She's had the chronic neck, shoulder, and back issues. She's chest up, squeezed down and back. She's got her abs pulled in. The reason we don't want scapular retraction is for many of our clients, they will over retract. They don't come back to neutral. If you have them scapular retract back to neutral, that's great. But most of your clients aren't scapular retracting back to neutral. They're overdoing it. Hence the reason I developed rotator cuff and labral tears. Hence this reason why so many of my clients come to me with chronic headaches, because they're like, my wife had chronic migraines because she was overly retracted. Her chest was too far up. So you have to watch that cue. Obviously, if it works for you, keep using it, but make sure it's working for your client, and don't just give it as a general recommendation. Because this is the client after I cued her more appropriately. I did a little bit of soft tissue work, but I also cued her more appropriately. And now you see a much different appearance, a lot less sway in her back. And she actually texted me the next day. She's like, I just want to let you know that I didn't even tell you I had low back pain, but I had chronic low back pain that wasn't changed by anything I did. But after you worked on me, my low back pain is gone, because I changed her cues. I changed her strategy as well. And this is how you can create instantaneous changes, by changing your clients' habits. You also need to cue them more as well. So the corrective exercise strategy we're going to do right now is, I should say, we'll do part of this, is we love the Rolga. The reason why we love the Rolga are the rolls or the grooves on the Rolga. I'll give you more information if you want to get one at a discount later on before we end up. So again, I'm releasing my left hip because that's the tighter of my two sides. So I want to make sure that I'm aligned over top the roller, and I go slow. The reason we like the grooves is because I can put my IT band and greater trochanter in that groove and not roll directly upon those structures. We go slow so the client can breathe and let go. Neurologically, let go. Teach the brain to let go of these chronically tight areas. We are also doing motor control training when we're doing our release, which is why we do it slow and controlled. But remember, once you release, you also need to activate. So we need our client to do something to reinforce what we just created. So I'm doing a band step out. It's one of our favorite patterns, but we can do this. We do this without the band, because if you can't do it without the band, you can't do it with a band. And if you notice, I always start my pattern with alignment and control. I want to align the head and neck and thoracolpelvic cylinder. I want to align the hip, knee, ankle, and foot as well. Keep the weight on a stationary leg and step out. It's basically coming off the hip hinge pattern. The two most important patterns you do with your client are hip hinge as well as breathing. So we step out, maintain that length, make sure you feel it in the back. Your client feels it in the back of their hip. So you're training the anterior pelvic rotation, but it's really rotation of the entire cylinder. So I just want you guys to go through this pattern here, because this is a very important that you understand this concept, and I just want to take you through breathing as well. So remember your tighter side. So my tighter side is my left side, not by much, because I did my corrective earlier today, so it actually feels better, but I want you to do this. So again, find your tighter side. Let's work on that tighter side. So I'm going to use a strap just so you can see where I'm breathing. Remember I said most of your older adult clients, they're belly breathing. They're breathing like this. They're mouth breathers. They breathe in, they breathe out. Breathe in, breathe out. Breathe in, breathe out. But nothing is happening up here. Nothing's happening down here. We want the entire cylinder being involved in the breathing process. So I'm going to use a strap for most of our clients because it's too hard for them to get their hands here without jacking their shoulders up. So a strap works great. A belt or a bathrobe strap, or at worst, use a resistance band. So I hold the strap like this. I'm going to turn around so you can see my back. Now I'm going to breathe in, focusing on expanding three-dimensionally. So top to bottom, side to side, as well as front to back. It's really the side to side and front to back. Breathing in through the nose and breathing out through the nose. Breathing in through the nose. I'm going to put my arms out so you can see. Breathe in through the nose and breathe out through the nose. And you'll see, as opposed to breathing here, where you just see, where you see that, you want to see a general overall increase in thoracolpelvic cylinder expansion and relaxation. Do it from the front now. So breathing in, I'll come closer. So you can see the strap expanding. So you want to get the cylinder, the entire cylinder expanding, and then breathe out. Breathe in and breathe out. We're thinking about being long through the backside of the head and neck and thoracolpelvic cylinder. So now let's incorporate that with our squatting now. So our hip hinge. So you just align head and neck and thoracolpelvic cylinder. Put your hands up on your pelvis. You're gonna breathe in again into the entire cylinder now, and then breathe out and feel as if your sit bones are going wider. So breathe in to come back upright. Breathe out to hinge. Breathe in, breathe out. Breathe in, breathe out. So I'm just breathing out through my mouth so you can just hear me breathing, but I'll be doing this through my nose the entire time. Go 2 more. Breathe in, breathe out. Going wide through the sit bones. Breathe in to come up, go breathe out, go wide through the sit bones. Because this position here will ultimately become my deadlift position. So this is my deadlift position. This is also my step out position. So now let's go into step outs. I'll do it from the behind. So long spine, stack that rib cage, hinge. So it's basically exactly what we just did. And now you step out, keep that weight back here in your glutes. You should not feel it in your back, you should not feel it in your knee. Step out, come back in, step out, come back in. So from the side, looks like this. So tall, hinge, keep that alignment, step, keep that weight back in the glute, hip, knee, ankle, and foot, remain aligned, staying long through the spine. So that way, you're loading the hip, you're activating the hip, you just release it with your myofascial release, and you activate it through your breathing. Now, let's just go back and recheck. We didn't do a lot. Let's go back and recheck single leg stance. So right side was good before, still good now. Left side was a little more challenging. This side, a little bit easier now. Not perfect, but a little bit easier. So the right side was good. Left side, a little bit better. I don't have to shift as much. My foot is flatter on the ground now without compensation. Let's check rotation. So rotate right, come back to center, rotate left, come back to center. A little bit smoother, easier to get to that side. Let's recheck forward bend. So one foot in front of the other. Right side, feels pretty easy, actually easier than before. Left side, much easier, actually way easier than before. So that was the biggest one for me that made the difference, was that forward bend. So that's why it's important to assess your client and have them reassess themselves so they feel the difference from your corrective exercises. And that way you can reinforce that alignment, that control, and the importance of the exercises that they go home with. Let me just finish up here. So we did a release, our activation, and then you would integrate it into your functional movement patterns, which is step 3 of the integrative movement process, is progress your client. This is where you integrate the new habits, where your client takes ownership of the new habits, and you progress your clients towards their functional goals. Take them through the squatting, lunging, bending, rotating, pushing, pulling, gait, balance, and carry patterns. So that way they learn and own and develop journship of these concepts and this information. So this is my client, Debbie. She's like one of your typical older clients. Fused big toe, bilateral hip joint replacements, spinal stenosis. She's got balance issues. She's got pulmonary lung disease, aortic valve stenosis. So this is Debbie. I'm just going to show you this real quick. When she walks and turns her head, she loses her balance. So again, that is very significant, obviously. But when she looks the other direction, she has no problem. So it's when she turns her head to the left. So when we look at her breathing, she's a belly breather. And when she lifts her leg up, you'll see this distension of her abdomen. You see a big bulge. It almost looks like an alien coming out of her abdomen. So I'll show that one more time. That's what happens when you become a predominant belly breather. You don't stabilize your core well. You can't use your core muscles appropriately. That's why breathing is so important. It impacts loading, it impacts balance, and upright posture and movement. Okay. So this is me taking Debbie through breathing. She's doing 3-dimensional breathing here. She's using the strap. She's cueing to stay long. Okay. Now, once you've done your correctives, you also want to reassess, but Debbie doesn't do good with a standing hip hinge. So we use a seated hip hinge and then a sit to stand. She does really well with this pattern. Most clients, we can teach them a hip hinge, but for clients that don't do well with a standing hip hinge, we find that this pattern actually works really well. She's cued to keep her neck long. And you saw her just correct her neck. And now she goes sit to stand. So that way we hip hinge, sit to stand to learn how to upright and load her feet. So great way to take the hip hinge right into the upright position. And now we always make the task challenging to your client. So now we're going to teach her how to maintain alignment and breathing and do a balanced sort of static hold. Again, for a lot of your clients, this is not hard, but for Debbie, this is really challenging. So I'm cueing her, long spine, 3-dimensional breathing, and maintain this alignment through the pattern. And she's like, wow, this is really fatiguing. And then we always do dual task. Shout out to my friend and colleague, Ryan Glatt, with Brain Health Trainer. The importance of dual task, because most of your clients fall when they're doing multiple tasks. So you want to encourage them to do multiple tasks as they do their functional patterns, like stepping, controlling, maintaining that neck alignment, maintaining 3-dimensional breathing, so that way they reinforce the habits that you're helping them create. So your program would look like this: 60-minute session, do your assessment and correctives, use your functional exercise progressions, do reassessment and corrective exercise work, give them their homework. If you only have 30 minutes, just pare this down, use half this amount of time, or make them come in early and do their correctives and self-assessment on their own. The foundation to help you become an ally in health, to discover the root causes, to give you and help your clients create an individualized and systematic approach, and to give you strategies, your clients' strategies for life, sport, and work. The integrative movement system. Posture, pain, and performance are linked. When you improve posture, you can improve performance, and you can also improve how your client feels. But focus on posture, postural strategy, and performance. Don't focus your client on pain. Focus on the functional outcomes that they are going to achieve and that they are achieving. Take them through a very specific process of assessment, address using corrective exercises, that motor control training, and then progress them to functional exercise progressions. Use the appropriate progressions, and that way you have a strategy for safely and successfully helping your clients achieve their health and fitness goals. And that's how you become the specialist for your current clients and attract more individuals that need, want, and will pay you for your expertise. If you're looking for a foam roller, the best foam roller, the Rolga, my buddy and colleague Rusty and his wife Dana are part of Rolga. They're offering you guys $30 for the Rolga. Just email rusty@rolga.com. Just take a screenshot of that and they'll get you a Rolga out, free shipping and handling. Just email Rusty, say OSAR as your code that you heard about it from here, from the Functional Aging Institute, and he'll send you a Rolga for $30. I believe it's $45 on Amazon. So I just want to leave you with this thought. What is success? This is my favorite poet, Ralph Waldo Emerson. And my client gave me this poem, patient, my first year in practice. And I read it. It was a really cool poem. Then I put it away. And I was moving and I found this poem. And basically the last line of the poem goes like this: what is success? Is to know that even one life has breathed easier because you have lived. That is success. My friends, you have the ability to literally and figuratively help your clients breathe easier by educating, empowering, and helping them excel, perform at their best. So thank you for all you do. Thank you for allowing me to be part of your journey, for allowing me to be part of the Functional Aging Institute and community. If you have any questions, I've got a few minutes. We'll take a couple questions. I know you have another session. We're also doing our integrated movement system training online because of COVID, we can't be in person. So we are going to do this online. If you're interested in learning more about the system and how it can help you and your older clients in your facility, just reach out to helpdesk@fitnesseducationseminars.com. Mary will give you more information and details on that program when we release it next week. So just reach out and let her know.
Evan, you have a couple of questions. Did you see them already? Did you see your questions? I can read them to you real quick.
Okay.
Joey, it looks like Joey wants to know, would you please expand a little on not employing scapular retraction?
Yeah, I did answer that. Remember that you want to retract back to neutral, not over retract, not overly depressed. So just get them back to neutral, but not further into retraction, which a lot of us have been taught to do, is to retract as far back to pull the shoulder blades all the way together. We don't want to do that.
And then the same gentleman, Joey, he
Yep.
also, you already answered the second question? For the
Yes.
kyphotic client whose movement is
yeah.
to shrug the upper traps. Okay.
Yeah, so kyphotic client that tends to shrug their upper traps, that client does need a little bit of scapular. Just bring your scapula back, but don't have them keep them that way. So you want to make sure, bring them back, but now you have to train them to keep them there, not keep going down, and not to lock them into position. You want them to move back from a more neutral position. So it's kind of a happy medium between getting them back to neutral and then training them to maintain that position and to reinforce that position. That's the functional progressions that we talked about during the presentation.
Perfect. And other than that, you have a lot of kudos in the chat.
Thank you.
Thank you.
Thank you guys so much. It's 11:30 on the dot. That doesn't happen too often. We're get you out of here right on the time. Thank you, Lisa, for taking care of the session and answering the questions.
You're so welcome.
Thank you for the kind comments. My brother Robert will be on later on today with alternatives to strength and training. So that's the reason I love working with Robert, because we're coming together to help you guys create strategies for your older adult to get them stronger, to help them perform better, and get them out of pain and help them achieve their health and fitness goals. Two Bald Brothers and a Microphone coming next week. So excited to join that as well. Thank you, Lisa. Thank you, FAI.
Thank you. Thanks, everybody.
Guys.